So my name is Lauren Elizondo, and I'm a physical therapist with the Center for Neuroskills. Sorry, a liaison with the Center for Neuroskills, physical therapist by background. So I've been a physical therapist for 12 years in a clinical setting, and then an additional 2 years with Center for Neuroskills. So I've worked in neurological rehab ever since I started my career. I went to A&M for undergrad and went to Texas Women's in Houston for physical therapy school. But I just really have a passion for neuro rehab and treating both children and adults in a neuro rehab setting. So my experience spans from outpatient neuro rehab to I've done a little bit of pediatric home health to inpatient rehab, then back into the outpatient rehab setting when I last was treating. Definitely have worked with kiddos after brain injury, stroke, kiddos with cerebral palsy, different neurological conditions. So I'm happy to share whatever advice and experience I can with y'all. I'm also a mother of 4 babies. So I believe that that's put a whole kind of new perspective on things, for sure. I mean, I can't say I know exactly what y'all are going through, but I definitely have a tender heart and want to help y'all as much as I can. So yeah, feel free to ask and grab my card if there's anything I can help with after the presentation. So full transparency, this presentation was created by the neuroscientist for our company. So Center for Neuroskills is a program in California and in Texas. We do work with adults and pediatric patients. But just so you know, if some of these are very scientific slides, I definitely added in my own content to this, but some of it is a little more scientific and above my head than what I learned in physical therapy school. I also have the joke on mom brain, and that, you know, as I've had more children, I feel like, you know, my own forgetfulness has stepped in a little more. Plus we're multitasking as parents, right? And constantly using our brain and trying to remember things and trying to help our kids however we can. So anyway, full transparency and disclosure there on that part of it. Are y'all familiar with post-acute rehabilitation, like Center for Neuroskills? I know we talked earlier a little bit. And comprehensive treatment programs, so including physical, occupational, speech therapy. Probably y'all all been exposed to the therapy world in some form or fashion. Okay, so we'll touch on that a little bit too. What about just neuroplasticity? Have y'all heard that term before? Yes. What is your take on neuroplasticity?
Oh gosh, I'm gonna sound so stupid.
No.
I guess
No stupid comments or questions.
that we can't fix what's already damaged, but can find new pathways in the brain.
Yes, perfect. New pathways. Yes. That was great. See? That's perfect. See? Presentation's done. We can go. No. No, but it's all about learning new pathways. So even if there are neurons, which are nerve cells that are damaged, we can reroute and learn new pathways. So exactly. And we're going to talk all about the principles of neuroplasticity and how you can maximize neuroplasticity for your kids. Okay. All right, we are doing just a very, very quick anatomy review, just to kind of talk about the lobes of the brain, but I know y'all are probably pretty familiar with that. We already talked about the definition of neuroplasticity. We'll get into that a little bit more. A neuron is a nerve cell. So, and then also talking about ways that brain injury can hinder that communication from one neuron to another. Define neuroplasticity and all of the principles that go along with it, identifying ways to promote neuroplasticity, and then describing rehab interventions that can maximize building those new connections. So this is a little, we have some of these at our table too if y'all find this useful, but it's just a good little reference and showing the 5 lobes of the brain stem, and all of the functions that kind of are correlated with each lobe of the brain. And you see a lot of cognitive or speech rehab in really any of those lobes of the brain. Like the frontal lobe really controls the decisions, problem solving, verbal expression, the temporal lobe controlling that selective attention, so different types of attention, the parietal lobe in production of speech. Occipital lobe does a lot with vision and visual processing. And then, of course, our cerebellum, that's kind of our motor coordination and balance center. Brainstem's going to control a lot of our autonomic nervous system, and those just like normal functions like heart rate, respiratory rate, all of our vital functions are controlled in the brainstem. That's just a good little review. And then it, on the right side shows some common impairments and changes that you may see after brain injury. As you know, I mean, this is not new to y'all, but brain injury is, there's multiple facets of brain injury. It's going to affect all aspects of life, learning, skill acquisition, your ADLs or your activities of daily living, and interfere with things. But we can do things to improve all of these things, even though these are consequences of it. And then again, just a little more of a list, just showing all the potential consequences. Of course, we know weakness can be either contralateral to the injury. You can have weakness in both upper, both lower extremities, or weakness in one extremity. It can just really vary depending on the type of brain injury. Changes in sensation, seizures can be pretty common after brain injury. Headaches, difficulties with speech. We talked about cognitively already. Difficulty with concentration, memory, processing, all of those things, and then different behavioral and emotional effects too. Okay, so finding a program that really addresses all of these things, making sure you have a medical team that a good oversight for your child, including neurologist, physical medicine and rehab, a primary care physician that's overseeing things, and making sure your medical team is communicating so that you can fully address all of these things. All right, this would be, these are pretty cool little videos to show that normal neuron firing like we were talking about. So these little circles are the neurons, and then they send the signals through that axon, that yellow part of the nerve cell, and then out to the other neurons. So we've got a little visual for you. Cool, huh? So I liked this example because it's really hard to picture, even if you look at a picture of the brain or you look at a picture of the nerve cell. But there are as many neurons as there are stars in the Milky Way. So over 100 billion neurons in your brain. Yeah, right. A lot. Yeah, I liked that analogy. The brain physically stops growing at the age of 18, but changes can continue to grow, occur throughout the lifespan. And then as far as neuroplasticity, you're going to see the most rapid amount of change before 18, but that does not mean you won't continue to make neuroplastic change beyond 18. Hang on just a second, it's thinking. And a presentation wouldn't be a presentation without a little bit of technical difficulty. Right now it's thinking, and I'm like, it's exactly what we're doing as we're processing all of this. It's like, PowerPoint is not responding. Would you like to restart? Nope, wouldn't like to restart. Okay. Neurons stopped. Okay, so sorry guys. There we go. So we went over the normal firing, and here's the video to show, like you said, when there is the nerve cell damage or death, it's kind of working to rewire. or sorry, this is showing the impaired signal to the neuron. In a second, when we define neuroplasticity, we'll show you how it makes new connections. But this is showing just the damaged neuron firing. So we'll show that one more time. I'm like, maybe it was our videos. Our animations are making it the PowerPoint not respond. Okay. So just diagnostic-wise, your kids after injury may have had several of these or one of these different diagnostic tools, but MRI, PET scans, SPECT scan, MEGs, EEGs, CTs, and MRIs with diffuse tensor imaging. Are y'all familiar with all of these? Yeah. So it is, an MRI doesn't expose a child to as much radiation, whereas CT scans may more so expose to radiation. So that's why one may be considered over the other, but an MRI is going to give us more information. And this one's actually the SPECT scan. So this is just to kind of show an example too with MTBI or a mild traumatic brain injury or concussion. So you see on the left, that's the normal blood flow and imaging of the brain there, normal metabolism. So you want to see that good red, orange, yellow. The mild head injury, that was actually a football athlete that was walking and talking. So didn't have a lot of symptoms or consequences presenting whenever that imaging was performed. And then you look at that one compared to the severe head injury, that doesn't look that much different. So it just shows that, even though someone can present, like they're functioning well, their brain may be, lacking a lot of that. So just reiterating that absence of evidence is not proof of absence. So just because that person may appear normal, there can still be effects or that injury there. All right, here we go. Neuroplasticity is what? Yeah.
Oh, okay. I got nervous.
You did great. The science of how the brain changes its structure and function in response to input. That's kind of like the medical or the technical definition. But basically, the brain's hardware, the brain's wiring, the signals from one nerve cell to the next. And we talked about that a little bit earlier, but just talking about how the child's brain is growing and more able to have that neuroplastic change before 18. However, that process can continue to happen beyond 18. It's just happening more rapidly in 18 and younger. Synapses, so those are those connections between the little neurons, the synapse, where the signal is sent, connecting to the next. That little space is the synapse. So synapses increase from 2,500 to 15,000 per neuron from birth to 3. So even like in babies, showing how like neuroplasticity is occurring even much more rapidly in that young age.
Got a question if you don't mind.
Sure.
So what if the kid would like to neglect using the disabled hands? Like, how do you approach that? Like, if excited to use it, that create more force in there to be most likely to work in the future, of course. But
Right.
the
Great
child is
question.
like, open, no, that's not gonna work. I have this. I don't need this. That, like, literally.
So have learned a compensatory strategy.
Yeah, like how to
Yeah.
make it exciting. We tried video games, we tried things that she likes, because that will make it kind of like doomed literally.
Yeah, so, well, those are principles of neuroplasticity that we'll talk about. So the use it or lose it as part of the neuroplasticity principle and idea. That's just one part of it, though. but you want to be sending that input and connection in order to strengthen the signals. So ideally, yes, trying to find things that she enjoys doing or likes to do, or right, yeah, and then that goes into salience, which is another principle too. So if it's not an activity that the person enjoys or is meaningful to the person, then it's not gonna strengthen that connection, right? So yeah, you're on the right track with like, a video game or maybe something she's interested in.
The more she neglected, disliked to do it, kind of like, it feels like it get worse.
Oh, yeah.
The brain will kind of like shut down.
So maybe more spasticity, is that what she's having, or is it?
Like,
yeah.
That hand in motion, for example.
Yeah.
She likes to climb, but just
yeah.
Safety wise too, like you can't have it in one hand.
Right. Yeah. Right. Yeah.
To get this neural connected, but if she's refusing, what are we gonna do?
Yeah. Yeah.
Is this going to work by itself even without using it?
Yeah. So the idea is giving input or finding, ways to, make it being motivated, or combination therapies, not just occupational therapy, but if she's doing another therapy, trying to overlap the disciplines too, and know what the ultimate goals are between disciplines, but definitely making it meaningful and enjoyable, and understanding why they're doing an activity to then tie it into that, try to improve that function in the side. But yeah, you're on the right track with like, you want to provide that input to strengthen the connections from the brain to the muscles that are telling the specific muscles and movement patterns to work. Yeah. Just making sure. So just think of it too as like, just say if you or I were doing a bicep curl to strengthen this muscle in our arm, neuroplasticity, we're strengthening the muscles in the brain to then send those signals to the muscles that are doing the movement pattern. So this is just some of the things that we'll get more so into principles on the next slide, but cortical reorganization. So that's just kind of rewiring or remapping between the lobes, like I showed you in the very beginning, that anatomy, all the parts of the brain talking to one another. So that's what cortical reorganization is building all those new connections. Neuroplasticity requires structure, repetition, and consistency. So high intensity, high repetition, experienced staff. So again, going back to your medical management team, all the physicians that are overseeing care, from primary care to neurology to any other disciplines, and then experienced therapists, so PT, OT, speech. We also in our program have counseling and education therapists. Every program is going to be unique and different, but finding one that is comprehensive and looking at all of these aspects. And then practice, effort to perform is meaningful and functional for the person. And this, that was a good segue, your question, in talking about all these different principles. So use it or lose it phenomenon, y'all have heard this before, right? Yeah. Salience, making sure that it's meaningful to the person. Specific is the task specific to what they're wanting to do. Like, I'm not going to do exercises lying down if I'm wanting to work on getting my child to be able to ride a bike. I'm going to work on riding the bike or riding an adapted bike, something within the function. So making sure the tasks are specific to what you're trying to improve. Repetition and intensity, I feel like those kind of go hand in hand. Like when we're working on an exercise or an activity, we're not going to do it three sets of 10 reps, right? We're going to work until they get tired of the task, or you're seeing the movement pattern maybe decline. That's when you're going to take a break, not put a set number of sets and reps on it. Sometimes you have to put find a motivating way to work on it. Like, okay, we're going to do this for 5 minutes with your left arm, and then we can do, X, Y, Z to make it more motivating. Just make sure I didn't. And then going back to that use it or lose it. So when we're learning a new skill for the first time, just like when we're learning to walk for the first time, like a baby is practicing that skill, you know, stumbling, practicing that skill over and over and over again to strengthen that connection. So it just kind of goes back to that. And I know some of your kiddos are working on that, or working on sitting up, or working on just standing, you know, whatever skill they may be working on. It takes hundreds to thousands of repetitions to perfect a skill and to promote that neuroplastic change.
I have a question.
Yes.
Okay. So, are you familiar with PDA?
Yes. Yes.
Okay. So, do you think that neuroplasticity would work on something like that? You know, not positive reinforcement, but how do you get like a
Yeah.
reroute that? Okay, this is not an appropriate laughing matter, and consistently do that when it comes to cognition. I wonder if neuroplasticity works with that, or if it's more towards like physical results
Yeah.
versus cognitive results.
I would think it would depend on, what is causing that. Is it the injury that is causing that part of the brain that works on the dysregulation, you know, or are there other things like we talk about?
The reaction doesn't match the emotion, but how, like, I'm just wondering if neuroplasticity would work
Yeah,
or something like that.
that's a great question.
I need to find someone.
No, yeah, and I think maybe what's causing it, like, is it the extent of the injury? Is it, are there other things playing in? Like, we talk about neuroendocrine dysfunction later on in the presentation. So are there other things we can look at to see if that helps? Is it, are medications having any effect on that too? I think it's kind of a multifactorial thing, but I don't ever think it hurts to try and see if, like reiterating that positive or the activity, the response that you want.
Right, and it's not always like, no, because then that's like a negative way, you know what I mean? We're supposed to stick with positive reinforcement when it comes to neuroplasticity.
Right.
But if you're constantly saying, no, don't laugh, that's not a laughing matter.
Yeah. I think talking about like appropriate reactions too, so that like speech therapists, but also we have a counselor that works with our patients and our families, so counseling, also psychology and neuropsych. I feel like all of those kind of may play into that, and like, again, going back to the expertise of your treatment team, or collaborating with multiple disciplines. Yeah. Yeah. And always, you know, I'm a proponent of, you know, trying something out or trying intervention out and seeing how it works. So there's a lot of that with, as someone goes through therapy, and your kiddos will be going through therapy on and off throughout their life, you know, to get to work on new goals or new things or changes you may see. So, good question. Yeah. And just want to reiterate too, on this slide, it's never too late to start. So even though the pediatric brain is more plastic to change, up to 18 changes can occur throughout adulthood. With our level of care in our program, we tend to see younger patient population, but we've seen changes in patients that are older and patients years post-injury. So we definitely want to get in early intervention and treatment right after injury, but we'd continue I would continue to seek treatment years post-injury. And y'all talked about this. I just want to hit on that again. So helping your child too to understand when cognitively able, why neuroplasticity is important. I don't know what age your kiddo is, but even like talking about some of the things, and there's different books that talk about, like The Fantastic Elastic Brain. What, she doesn't like it?
Like, I'm telling you, it's not going to work.
Yeah.
You get a slap from the other hands.
Yeah.
She's not going to hesitate.
Like, leave me alone.
Well, it was worth a try because I like that book. Being a mom PT and a neurotherapist, I'm like, this is a great book. But there's something for everyone. Maybe there's a different book for her. really those last 5 we talked about. Just kind of segue into this. Time matters. There's not only use it or lose it, but also use it and improve it. So lots of repetitions to further improve the skill. Age matters. We've talked about that already. Generalization and interference. That interference goes back to it can take more time and more repetitions to unlearn the compensatory strategies. So if someone develops, say someone's just using their injury affected their right arm and they've just learned how to reuse this arm. If you're wanting to then incorporate the right side again, it's going to take more time and more repetitions, but change can still occur. Generalization. So one activity may improve multiple functional things. So you do want to, like we talked about in the last slide, work on an activity that's specific to the task you're trying to improve, but sometimes a skill can generalize. So like sitting on one of those Swiss balls, right, and working on your sitting balance may improve your core strength to then perform a standing or a walking activity. As much as you can, though, it is important to, like we talked about on the other slide, make it specific to the task you're trying to improve. Okay, I'm going to do this, but it's going to make me restart PowerPoint again, but this is cool, so we're going to try it one more time. It's worth it, right? Even if we need to restart the PowerPoint. Yeah. So just showing that even if, if the nerves or the neuron is damaged, we may still be able to strengthen that connection. If there's cell death that occurs, though, we can reroute things. You can also build new neurons. So that is a thing too, as you're doing these neuroplasticity principles, that new neurons can grow.
Is it different if they have a DAI?
No, the similar principles. So there's going to be more, with a DAI, more lobes of the brain that are affected and possibly more of those consequences that we talked about in the beginning, but all of these principles are still apply. Told y'all. Sorry. I'll give that feedback. I know. I'm like, it was worth it, but every time they made me restart it.
It's probably different, but at least in my daughter's case, is there like an education with this when it comes to physicians? Because I'm sure a lot of us here have heard like they'll never this, they'll never that. Yeah. Is there like a decorum of people that understand what neuroplasticity is and can at least like speak upon that versus giving us the negativity that they won't be able to do so?
Yeah, I feel like that's a whole other.
I know it's not wrong, but that's just my mama coming out.
No, I feel like that's a whole other breakout session. I feel like bedside manner 101. Yeah.
I just feel like if this was like at least when she was in the NICU, I heard this in the NICU.
Yeah.
Sorry, I'm like a moment. But like, I heard this in the NICU, that probably would have changed my whole view.
It gives you hope.
Yeah.
Right. Yeah.
That was my soapbox. Okay.
No, and I feel like everyone's training is different, right? And everyone's specialties are different. I just feel like I'm never going to say never, and I'm never going to take away hope completely, right? And like research is constantly evolving and changing. Like in med school, physical therapy school, we're given facts, we're given articles, we're given literature. We can tell you what the literature says, but I'm never going to say like,
Love that.
yeah.
Thank you.
That's me. Yeah.
I love that.
Okay, and this just, again, more neuroscientist, neurospecific, fancy terms for y'all. But angiogenesis, synaptogenesis, dendritic arborization, neurogenesis. So this is just showing everything that's going along with that, that video we showed with the signals being sent from one neuron to the next. With angiogenesis, all of those new blood vessels have to form. With synapse, synaptogenesis, all those new synapses have to be created. The dendritic spines, those are those very like nerve endings that look like a beautiful tree. But it just shows that process takes time, and this is why it takes so much time and so much repetition, because all of these little changes are happening from one neuron to the next.
With seizures. If the person has seizures, is there a regression in like learned abilities when there's neuroplasticity going on, and then you're having seizures as well? So how does that play in neuroplasticity? Because if the person is having seizures, then they are unlearning basically what they are learning.
Sure. Yeah, sure. Because it's like almost like, is it causing another mini mild brain injury? Yeah, I mean, that's a great question. I definitely feel like with anything, right? Even like a break in therapy, like ideally you have a good home program set up and you're carrying things over in home, but you may, like, what's causing the regression, like it may cause a regression. I can't say definitively yes or no, but I think still treating it as like, definitely letting your care providers know if you see changes, letting your therapist know if you see changes or regressions, and then they can focus on those things. But I wouldn't give up hope that you can still continue to keep making change. Does that help? Yeah. Didn't fully answer, but it does depend. Does depend. Okay, and then this is a good kind of summary here. So experience-dependent change can occur at multiple levels of the central nervous system. So showed you all those little cellular levels, vessel levels, from molecular or synaptic level to cortical maps, and large-scale neuronal networks. So that cortical reorganization is speaking to the whole reorganization of the brain. Nor is substantial recovery or restitution of function likely in the absence of targeted intervention. So meaning not giving any intervention or therapy or management of the the deficits that you're seeing. So this is moving into, the importance of a comprehensive rehab program, which we've talked about already a little bit, but those circuits are modified by experience and learning. So not only learning with the experienced professionals, but then carrying over what does the program at home look like? How are they being motivated and stimulated at home? And making sure that's meaningful for your kiddo. Harnessing this inherent ability for neuronal circuit change may be essential to maximize the benefit of rehab. So it's a lot of words, but it's just reiterating again the importance of intensive rehab. So how can we promote neuroplasticity? So some of these things are not my expertise. We generally learn these in physical therapy school, but knowing specific things about medications and what medications your child's taking, getting a neuroendocrine evaluation, definitely structured rehabilitation, like we've been talking about, sleep evals, and exercise. So have y'all had, your kiddos had sleep evaluations? Versus, yes.
6 years of me telling them.
Beneficial? Beneficial? Yes.
She's on a BiPAP, and she said she doesn't notice a difference. There's a huge difference.
See, there's a difference. And then, yes, sleep.
No?
No?
I'm looking at the neuroendocrine evaluation. I've never heard of that.
I was gonna say, what did
Endocrinologist, or if there's a neuroendocrinologist specifically, but an endocrinologist. But yeah, there's one slide on that. I wish that's definitely not my expertise. I'm happy to send you more information about it. If you want, just make sure I have your email when we're done. But this is just kind of, how we can most efficiently promote neuroplasticity. It's multifaceted. It's not just the rehab, but how can we make sure they're getting the most out of the rehab by looking at all of these other things as well. So medical stability, right? I speak of this comprehensive rehab program. the company that I work for, typically we see patients after that acute rehab phase. So there's a level of medical stability there, right? Like your kiddo's not going to start 4 to 6 hours of therapy a day right away. They're going to have to get to a certain level of medical stability to get there. So that's where that medical stability is talked about at the beginning. We then want to increase functional capacities through remediation, compensation. Sometimes compensatory strategies are taught to be able to get through a skill or to get someone safely home or to get them successful with doing a task. So sometimes we have to teach a compensatory task. It's not always avoidable. Sometimes adaptive equipment is needed and our environment at home needs to be modified just to make things more successful for your kiddo in home and at school, right? And then we want to improve the person's ability to engage in daily activities and participate in meaningful roles. So at home with their siblings, with their peers, at school, also being back out in the community again, if that was something they did before, if they're older. Post-acute brain injury rehabilitation, I talked about a little bit. This isn't something, it's an acronym, PABIR or PABIR, if y'all have heard of that before. This isn't something that insurance recognizes as its own little box, like outpatient therapy or home health or acute rehab. It's not recognized by insurance yet. So that's why our level of care isn't covered by like Medicaid, Medicare. But there are other, if you do have Medicaid, there are other intensive programs that you can get through Medicaid and other outpatient programs. So that doesn't mean just because you can't specifically do the post-acute brain injury rehab that there's not resources for y'all. So I'm happy to help connect in any resources I can. But this kind of dives deeper into what that post-acute brain injury rehab is. So it is a community-based treatment approach. There are also community-based treatments out there where they do physical, occupational, and speech therapy, like in the home, in community, where it's a non-hospital setting. Our facility isn't in a clinic, but then in our inpatients, patients live in the homes, and we're working to reintegrate home to community. But then in our day program, patients are living at home and coming in for therapy during the day and doing that 4 to 6 hour program. Immediate utility of skills training. So skills are taught in the context that they'll be used, making them more likely to generalize. So as we talked about, generalization is one of those concepts of neuroplasticity. Dignity of risk guided failure. So allowing our patients to make mistakes in a safe therapy setting and learn from those mistakes helps in that remapping. And then reestablishing control. So control of the situation, control of their goals, control of their things that they want to improve upon. And of course, family education and support is always huge. We get our families involved from the beginning. So making sure you're communicating with your therapy team, you're learning about the different techniques the therapists are using, the ones that you can safely carry over at home, being involved in that home exercise plan and program. And then also y'all are using all of your community resources by being here today. So Team Luke is a great organization that helps get y'all resources. So y'all are doing the right things by being here today. All right, and then these 5 disciplines are unique to Center for Neuroskills, but whenever you're seeking out a comprehensive rehab program, learn about all the disciplines that the program offers. So again, physical, occupational, and speech therapy are kind of like those foundational therapies, but these adjunct therapies are important too. Counseling, some have behavior. We have behavior analysts at some of our locations. Some have neuropsych services, so there are so many different avenues and help that you can get to get that multidisciplinary approach. We do work on reassessing progress. That's something therapists have to do, of course, but I feel like that's something that's very beneficial in talking to your parents and getting them involved in the goal writing and showing, you know, how your kiddo's progressing through therapy. And that's going to change, right, from when they're younger as they progress through the lifespan. Carryover and repetition is something we talked about already. Cognitive and physical intervention. So not just like separating PT, OT, and speech too, but collaborating the disciplines and trying to work on more than one discipline if you can, is also another way to promote faster neuroplastic change. We've talked about compensation quite a bit already, but neuroplasticity is going to be occurring during the rehabilitation process, but it's also important to continue carrying that over at home and what you're working on as well. It's a balance in, you know, that compensatory approach and remediating or restoring that deficiency. So we talked about some compensatory things, but you know, you may have to utilize different orthotics for like the ankle or foot, or splints for the hand, or different assistive devices to walk with. So those are examples of compensatory approaches, but you can still work on that neuroplastic and remediation as well, and kind of, you know, find out what is the best balance there. So these are just some examples. There are tons of interventions that you may have seen and that your kiddos may have tried in therapy. These are just some examples, but constraint-induced movement therapy, are y'all familiar with that? Just because you brought up the, is like putting a mitt on the stronger side. So you're like forcing the...
They cast.
Casted, yeah. So sometimes that... Okay. Yeah.
She took her hands out of the cast. They took her to the hospital.
Yeah. Houdini. So for it to be like a true constraint-induced movement therapy, it's like 90% of the day if they're casted, they're wearing the cast without taking it off. But I've had my patients, typically OT is guiding this, because it's typically with the upper extremity that they're working on strengthening. But had a patient's parent sign a contract that they're going to carry it over, so that 90% of the day they're wearing the mitt, and then giving them a list of activities to work on to strengthen. So that's the kind of like, you know, to the point method of doing constraint-induced movement therapy.
And, our daughter had side preference as well, and they just structure and it didn't work. Yeah, it took a while. It worked so well to begin to get a preference for the other side.
Yeah. Did you have to sign something? Just because, like, too, that can be seen as a restraint depending on the setting. So
we like, it was discussed, and we did it ourselves.
Gave
She was
consent.
very,
Yeah.
Very little. She was
Oh,
less
yeah.
than a year old.
Oh, yeah.
Different.
Different.
I know that's gotta be. I
Yeah.
was gonna say we have a similar, and then
No, but the problem is with it is because her arm is always in fist, the other one.
Yeah.
So she's like, there's no point. If even we put her in cast, she cannot open this hand and
Yeah.
use it. Yeah, it's kind of like, but they said if you keep training it, she will, which is, we kind of lost the whole episode.
That may be in conjunction, though, with spasticity management, making sure she has the spasticity management to where she can get her hand open, or have the range of motion.
Closes, but she cannot open it.
Okay. Yeah. So maybe in that therapy, but in conjunction with other things, because it has to be at an appropriate stage. Like, you have to have an appropriate amount of movement to be able to do that technique.
Yeah, I was gonna say the paddle is how my daughter started,
The neuro-IFRA paddle.
and
Yeah.
so she got it to at least that open position.
Mhm.
She did that for as long as she could tolerate. Then you move it to, you know, more incline with the stable stretch.
Yeah.
And then, but it does, you have to have your PM&R manage the spasticity.
Yeah, so I saw that a lot in outpatient. So where we had to manage the range of motion and the spasticity, whether it's medication, Botox injections. Some of my patients had pumps that helped manage the spasticity.
Block too, which I heard with it quite a bit, but and that one's supposed to be a lot stronger than the Botox.
Yeah,
I'm thinking
more
the name
general.
of it, but supposedly it went up from a few $100s to $10,000 an injection.
Yeah.
But it's like a nerve
Phenol?
phenol.
Phenol, yeah, stronger. Yeah, so it may be a situation where range of motion and the spasticity has to be addressed before you can move to that constraint-induced technique.
Yeah, they talked about like doing Botox in the sun and then serial casting.
Right. So the serial casting is going to work to improve the range of motion so that then they have the motion to move through to get there. Yeah. Yeah.
When you talk about cognitive neuroplasticity,
Mm-hmm.
that also feels like they become, like if they lose their memory or processing, how do you push them through
Mm-hmm.
those areas?
Yeah. So memory specifically, or
But in our case, both processing and short-term memories.
yeah.
Yeah.
Yeah. So I think definitely. So continuing with the high repetition, like I don't know, is he doing speech? You said he, right?
Yeah.
Doing speech therapy right now.
Yeah.
So I know there's all kinds of different like apps and equipment and things now too to get more hours in per day to where you're again getting that high repetition and intensity to promote the change. So it's probably a balance in that versus like an aid to work as a compensatory strategy is what I was trying to say.
Yeah.
Finding a balance between the two.
All the time.
Mm-hmm.
Everything from Go Fish and, Uno was especially helpful with like the colors and then moving into colors later.
Yeah.
We did a lot of cartoons and those.
Yeah. So, and then that was interesting to her, right? So yeah. At that stage, like again, finding, depending on age, what activities or things are motivating, like good strategies that they'd want to practice to reinforce.
Processing speed, those like I Spy card games.
Mm-hmm.
Pictures.
Yeah. And we use all kinds of things like that in our program, but then we have specific cognitive modules that our patients work through as they progress through the program. So just making sure they're challenged and motivated by the activities that they're doing too. Speech therapy, yeah, speech. OT also does a lot of, and PT sometimes functional cognitive exercises too. Yeah, so making sure your therapists are carrying that over between one another and between disciplines.
For PT, you would do that. You would have specific exercises with boxing, and you would like, each different one was a number, right? And then you'd be like 3, 4, 2, and then she'd have to remember those numbers.
The sequence.
Yeah, they still use that one.
Yeah, so I would do like counting, like working on categories, like, okay, we're going to name all the fruits that start with this letter, or, like while someone was doing a balance challenge or walking or, so trying to, if they are getting more than one discipline, incorporate those cognitive tasks across disciplines too. Sorry, I know I'm running out of time here. I did want to touch on just exercise being so important. So finding, even if an adaptation is needed, some type of physical exercise method for your kiddo to participate in. There are so many studies that talk about the effects of physical exercise on neuroplasticity. So making sure they're doing physical exercise daily and not being sedentary can also lead to other things like contractures, increased tone, other things as well. But if we're really trying to promote neuroplasticity, exercise is so important.
I love the FES bike.
Yes,
That's my
FES bike.
favorite
Yeah.
thing.
And that was on my, FES was on my list right there, but I didn't get to talk about that. But the FES bike would be another good example.
It moves for them. Some have hands, some
Yeah.
don't, but
So
it
you-
shows like a fun little scenery, I guess.
So say I want to work on my quad and my glute strength to help, push my bike or work on sit to stands or,
Like electrode games.
yeah, you put electrodes on the specific muscles and the muscles are stimulated as they're pedaling.
And it's programmed for
specific, and it actually saves the data. And it's
You mean
with
the
that
little
facility, but you can
stick
get it for your
muscle
home.
stimulator?
But yeah, of
You
course.
attach that to the muscle while they're
On the bike. So that's an FES bike. So the whole goal with those interventions, yeah, it's an FES. There's different brands, but it's called an FES bike, a functional electrical stimulation bike. Yeah.
Do you have any experience on your PT side with
Virtual reality. So we are implementing the use of Neuro Rehab VR. It's a specific type of virtual reality in our Dallas and our Bakersfield locations, but that's in other therapy programs as well. Research is growing on virtual reality, but again, the idea with that is that it's tapping into like a fun and a meaningful activity for someone while they're working on different things. And you can work on,
She was able to stand in the VR before she could stand without the VR.
yeah,
Because she stopped thinking about standing and was busy doing things like
a shopping task. Yeah.
So
So,
she had to grab things off and she
yeah.
had to stand and move around before she could do it.
Yes. Yeah, so that talks about, so that also speeds up neuroplastic change. So again, talking about carryover between more than one discipline. So like with the VR headset on, you can work on sitting balance, you can work on core strength, you can work on standing. And like you said, it can also kind of take your mind off of the task to maybe separate some of the things that may be preventing the person from sitting or standing. Just want to reiterate too, sleep evaluations, at least 50% or more of children with pediatric brain injury have a sleep-wake disturbance. So our brain is undergoing a lot of healing as they're going through all the different sleep cycles. All of the sleep cycles are important. So you want to make sure and have your kiddo evaluated for that to make sure they're maximizing their sleep. They do like a sleep study. Then they may recommend different treatment after that. Yeah, possibly. Yeah, but then too, going in back to the neuroendocrine dysfunction, because that one's on here. Y'all all know this, but just as a review, like ways that you can maximize your child's sleep too, to see if that helps improve sleep. Like in our inpatient program, we don't have TVs in their bedroom, so just like thinking about things like that, even like, are they getting a lot of screen time before bed? Is their sleep time routine normal? What does their diet look like? Making sure caffeine intake isn't happening 3 hours before bed. What's that? Yeah, just because like the digestion, and that could affect cause them to wake up if there's reflux or other things going on too. These are just some general sleep hygiene tips to maximize sleep. So it may not always be like a sleep study and sleep equipment is needed. It could just be some of these simple things that are going to improve sleep hygiene. We hit on this too, but just making sure if you're suspecting some of these, the neuroendocrine dysfunction symptoms can kind of mimic some of the symptoms you're already having from the brain injury. So making sure those things aren't caused by the endocrine levels being off. So like this decreased muscle strength, impaired judgment. So some of these things we talked about, depending on what lobe is damaged, could be effects of the brain injury. It could also be provoked by the endocrine levels being off. So making sure those things are looked at too. I'm almost there, guys. See if there's anything else. So just going back to multiple things going into rebuilding the brain or promoting neuroplasticity, all of the things that we talked about, considering the type of injury, the severity, incorporating all those principles that we talked about, treating the damage however we can, and providing that intensive rehab environment as much as possible and carrying over those changes and things at home. Sorry, I talked fast towards the end. Y'all have any questions? I just have this last little quote here. Suitably impressed with the 86 billion neurons that glittered like stars in the skull, but overwhelmed by the idea that the constellations could be moved, shaped, and changed. So just the idea with neuroplasticity and making improvement. I'm supposed to send that to Rhonda. Yes, I will do that. Yes.
Does myelin come into play in myelin production or lack thereof? Is that playing a role in neuroplasticity?
Yeah, because that's the nerve sheath or the, yeah. Mm-hmm.
So it does have, I just, I mean, so if you have a child who doesn't have a lot of myelin,
Producing that.
it's more problematic.
Well, it may take more to help connect and build the networks and other avenues or ways, right? So it, yeah.
But it can still happen.
Right. Yeah. Yes. Okay. Thank you.
In the PT, in PT world of when you have a minimally conscious child, are you like, you know, repetition and doing those things, like, do you tell parents to kind of just keep doing like things yourself for your child? Because like, you know, my son's pretty much 24/7 care. He can't do those things. But like we still sit on the edge of it. We still do those things. Is that you just do the same range of motion?
Of course.
Is there anything like for that state of?
I say giving the brain as much stimulation as you can, and I'm sure y'all do that all the time. Like still talking to him, him or her, him.
Yeah, we're playing like Kendrick Lamar in his room. We're playing the things that he loves, right?
Yeah.
Football's on the TV. Oh, yeah.
And then when you see changes, like you know, communicating that with your medical team and seeing if there are things you can do when you see new changes, even if it's small changes, it may then be able to be built upon and promote a bigger change. So
that's what we're working on like pivoting out of bed and stuff, and like he's starting to use that core. You feel him.
Yeah.
You feel it. Like you literally are like, okay, you're helping us. And, you know. So that's why I was wondering, I was like, is there anything that is missed when
you
have those kids, you know, like that aren't verbal, that aren't like he's verbal in his own way, you know what I mean? I'm sure, but you know, it's like they show you.
Right. Yeah. No, I think still promoting, and you're maintaining and keeping other things going by doing all of those things too, in addition to possibly working toward neuroplasticity. So, you know, you wouldn't want to stop doing those things.
Right, just do what you would do if they could do it for themselves.
Right. Yeah.
That range, do that. It's hard because he's still in the facility, and so you have to rely on staff, and that can get hard.
Get challenging.
When it's not in your control. Like it's almost better when it's, you know.
And it's hard. Like I don't want to take away from the fact for y'all, whoever has multiple kids and the time at home. Like I realize all of that is a factor. And you're all doing great, but doing as much as you can to keep stimulation going at home is great. Yeah.
You find where it works, and like where you work with like these medicines. Like, oh, he just got Aflin, or he just got Zartane. Oh, time to move. He's gonna be loose. You know, he's gonna be this.
Right. So now maximizing that.
That's what we've learned. Yeah. To maximize, or when he's like really alert, really with it, like smiling or doing something, you're like, okay, that he's in the mood. Kind of like your daughter be like, she's kind of
right. So that's when you'd want to work on that sitting or, you know, the transfers or whatever you are to maximize the core strength and the repetition of that, just that functional movement.
We're hopefully getting him into a big DOC program. So.
Oh, good. Good. Yeah.
Hopefully. Like that's where we're showing right.
Oh, good. That's a great
we're like 16
place to be.
Accident, so it's just like one of those things that you have to really hit it hard when you know, like you said, you see it, like it's like emergement is happening. So
right.
I'm like looking at all of this like team, like come on, let's go.
The time is now.
Yeah. Like you feel that stirring.
Yeah. Thank y'all for coming. I hope y'all got a nugget of information. Hopefully more.
Oh yeah.
Yeah.